Welcome everybody to the PrecisCa Genitourinary Oncology Tumor Board. My name is Brian Reaney. I'm a professor of medicine at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. And I'm pleased to be joined today by a panel of experts, and we're going to talk through a number of kidney, bladder, and prostate cancer cases.
My name is Jason Abel. I'm a surgeon. I'm a urologic oncologist and associate professor at the University of Wisconsin.
My name is Maha Hussain. I'm a geomedical oncologist. I'm a professor at the Robert H. Lurie Comprehensive Cancer Center, Northwestern University, and I also serve as the deputy director for the Cancer Center.
Hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I specialize in abdominal and pelvic imaging as well as nuclear medicine. I'm glad to be here.
My name is Preechash Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University, focusing on GU malignancies.
So this is a 39-year-old Caucasian male who has a history of BPH and hypertension who was diagnosed with PSA of 6 clinical T1C disease. And we're going to talk about optimal management for a young patient with low-risk prostate cancer and a high-risk Decipher score. So late last year presents with a 1-month history of weak stream, had a remote history of hematuria that resolved in no workup, asymptomatic, gets a PSA check and it's 6.1. It's his first PSA because the patient's 39, unremarkable physical. He's treated for a UTI and started on Flomax, doesn't really have many improvement in symptoms. Gets a repeat PSA that's about the same at 5.7. You can see the free PSA just above 1 and the percent free PSA of 19 and a performance status of 0. So maybe before I go on, I don't know if Dr. Abel, you're able to comment briefly about sort of this use of free PSA and percent free in terms of, I mean, this patient's 39, obviously very, very young, but in terms of the decision to pursue a biopsy in such a patient.
Yeah, so I think it's difficult when you have young patients with family histories of prostate cancer because, you know, should you detect it or when should you detect it is the question, right? Because then when you do, you're kind of pulling yourself more towards needing a treatment. So I think in this patient with a looks like a is the free PSA there? 19.5. Is that what you're showing?
Yeah, that's what I'm. Yeah, percent free PSA. Yeah.
Yeah, and so with this pattern, I think it's very reasonable to offer a biopsy. It's tough because PSA as a biomarker can pick out some patients at risk, but it really is more of a shotgun approach. It doesn't really, the specificity is not high enough that we can use it. So we frequently would move to biopsy. And then again, you know, I think there's several different genomic classifiers that would, you know, people could use off the biopsy, you know, or that, again, to estimate risk afterwards.
So let's go through the case, and I want to come back to those genomic classifiers just to sort of give a rundown. So this patient has hypertension, erectile dysfunction, some reflux disease and spinal disease. Social history, relatively unremarkable. You can see the family history there, though, is remarkable for many men with prostate cancer, some at an older age, some at a somewhat younger age of 60, and a paternal grandfather, but sort of multiple family members with family history. And obviously this patient is 39. So early this year, this patient gets an MRI, has a sub-centimeter PIRADS 4 lesion in the right posterior lateral peripheral zone and undergoes a biopsy, Gleason 3+3 disease. And you can see sort of the various cores that are listed there, mostly with 3+3 disease, some high-grade PIN, et cetera. And then a Decipher score done on that tissue of 0.61. So I don't know if Dr. Abel or maybe Dr. Hussain can comment. I've not used the Decipher score a lot in my clinical practice of what is it and how is it applied in this case, in these type of cases.
Probably will refer to Dr. Abel, but I'm happy to make also some comments about this patient.
Sure. So I think that the Decipher score, again, is a genomic classifier based on expression patterns of biomarkers. Initially in radical prostatectomy specimens, there's a few similar type scores, but used to predict outcomes within 10 years of their prostatectomy. It's been validated in multiple different cohorts. The predictive accuracy is, relatively good, probably a little bit better than PSA or other things we have. So in this gentleman, anything higher than 0.6 is high risk, and lower than I think 0.45 is low risk. We don't use it typically a whole lot. So for a patient like this, it's difficult to interpret a Decipher score because in that either development or validation cohorts, there were probably very few 39-year-old gentlemen. So it's really hard to know exactly what that means for this patient. So it's an unclear risk. And then, you know, what the treatments, I'll let Dr. Hussain comment as far as any other risk stratification.
So I was just going to make a comment is that, and again, in medical oncology, we don't use the Decipher risk, just to be clear, in terms of like the minute you have a biopsy, that's what we go by. It's an approach that I think is much more urologists tend to use. And it's really looking at risk, though the original data was based, and Dr. Abel can correct me, was actually based on post-prostatectomy patients, predicting risk of relapse. This seems to have kind of moved into like earlier phases of the disease, sort of at time of biopsy. But to me, in a situation like this is a patient who in the first place shouldn't really have prostate cancer. He's awfully young. The fact that he had the hematuria, the fact that he had a PSA that was elevated, all of these things kind of flags in the context of a family history. I myself have had, this is not my patient, but I've had actually several patients over my career time, most recently even about 2 years ago, who are in their 30s with prostate cancer. To me, these are the kinds of patients that, quote unquote, the standards of care based on whatever ASCO, AUA, whatever guidelines, personally, I don't really think it applies. Part of it is because all the data were not based on people who are in their 30s. And this is the kind of patient, you're not going to be able to put them under surveillance. If they were 39 and developed prostate cancer, this did not happen yesterday. This was there, a while ago and there. So to me, this is the kind of patient that I would say I would err on. Again, this is a long conversation with the patient, but I would err on the side of actually definitive treatment for sure.
Yeah, no, I agree. I think the patient's age is really driving a lot of the discussion here, as opposed to say a 79-year-old where
that's exactly,
that score might influence you a little more. So just to turn to our question.
Dr. Rini, can I just jump in on
that? Yeah, absolutely.
We've had, I think, pretty good validation now on using the Decipher score on biopsy specimens on large cohorts of patients with multivariate analyses showing that you get an independent signal from Decipher separate from Gleason score, PSA, and clinical stage. So it's used, I think, a lot more both in urology and radiation oncology clinics. I think in this case, I totally agree. This patient needs treatment. The question is it safe to defer that treatment for a few more years? And that's, to me, why a Decipher score might make sense. It's not to let this patient know that you'll never be treated. It just means that maybe we've got a few more years without a much higher risk of erectile dysfunction, which may be a concern for a 39-year-old. The new radiation trials that are going to be opening soon, national cooperative group studies, are actually using Decipher as a mechanism to de-escalate and escalate therapy based on the score. So in addition to the clinical grading system. So I think we're going to see this a lot more, and we're starting to use it some in this setting.
Fair enough. Dr. Fromm, did you have a comment?
I'm sorry, just
sure.
Make a very brief comment.
Sure.
I think, Dr. Patel, I fully understand the validation of it, but the reality of it is this, and again, please correct me if I'm wrong, I am not aware of any set of data that took cohort of patients, a priori tested for this, entered into trials of treatment, and then looked at outcomes. To my understanding, the bulk of the data is more cohort data that is not prospective, looking at outcomes. And I think this is the part where I have concern about the trials you mentioned, about a priori using a biomarker that is not 100% 100% validated in prospective manner. And I do think that then applying it to somebody who is an outlier age in their 30s and say, well, I'm going to let you, we're going to watch you for 3 years and then maybe we'll consider treatment. That, to me, I would say, if this is a patient consulting with me, I'd be saying, go for treatment. The data doesn't really apply to you directly.
My understanding is that, we're following maybe a similar pattern to the oncotype in breast, where yes, it's cohort data, but it is prospectively treated patients. We're just using their tissue samples for validation. And so, yes, we have a prognostic signal, I think, with Decipher and maybe oncotype, but the predictive signal for these genomic classifiers is what is the subject of new clinical trials that'll be opening soon.
Thank you. Dr. Fromm, did you have a comment? I think you had your hand.
Yeah, so just an observation, the patient's imaging, sub-centimeter PIRADS4 lesion. So, and with a Gleason grade of 3+3. So generally, I don't think of prostate MR as being very sensitive for Gleason 3+3 disease. And this is a small lesion. It sounds like it was just a systematic, like 12 sample standard biopsy. I think it's very possible that the lesion seen on imaging, which would, presumably be the highest, grade of disease, was in fact not sampled, and the 3+3 disease could in fact just be incidental. So here, I think we have a case of some rad path discordance, and I would recommend in this patient, that he undergo a fusion biopsy where we can actually use the MR data to target the highest risk portion of the gland, and may end up with a higher, grade of disease in terms of the Gleason score, which could then, be informative in making the decision about whether to, treat him now versus later as well.
So thanks. This case has brought out a lot of issues, more than I thought. So it sounds, just to sort of sum up, it sounds like, the age of this patient is driving, I think, most, if not all, towards some definitive therapy, that the use of the Decipher score is not quite fully vetted in this setting. There are trials going on, and that I think Dr. Fromm made a really good point about the imaging, and that the imaging suggests there's probably some higher grade Gleason score disease there, whether you happen to biopsy it or not. And that maybe even above and beyond the Decipher score might drive you. Although again, in this 39-year-old patient, I think most of us would lean towards definitive treatment.